All right, so today we're diving into a procedure that's been making waves in kidney cancer,
Oh, yeah.
renal mass biopsy,
Mm.
or RMB as it's known.
Morimbi.
We're going to be looking at a 2024 review article from Nature Reviews Urology.
Okay.
It's called Renal Mass Biopsy, a practical and clinical pathologically relevant approach to diagnosis.
Sounds pretty dense.
Yeah, it is a little bit dense, but
Quite good.
it's good stuff, though. Yeah, lots of insights,
Yeah,
especially for folks working in the field, from clinicians to researchers.
absolutely.
So why is RMB gaining so much traction these days?
Well, kidney cancer is a major global health issue.
Right.
And unfortunately, both the incidence and mortality rates
Hmm.
are increasing.
Yeah.
And traditionally, we relied on imaging
Yeah.
to diagnose these.
Imaging.
But it can lead to some unnecessary surgeries,
Oh.
especially if you're dealing with benign tumors.
So you're going in for a procedure that you might not even need.
Exactly. Exactly.
Yeah.
And there was a study in 2019 that showed a significant proportion of partial nephrectomies.
Hold on. Remind me what a partial nephrectomy is.
Oh, it's the surgical removal of part of the kidney.
Okay.
These were done on tumors that ended up being totally benign.
Wow.
So that's where R&B comes in.
So this could have, saved people from having these surgeries?
Exactly. That's the idea. Yeah.
That's amazing.
It could prevent these unnecessary procedures.
Makes it a pretty valuable tool, then, for everyone involved.
Oh, absolutely. For both patients and clinicians.
Yeah.
Helps to avoid those unnecessary surgeries.
Right.
And allows for more personalized treatment plans.
Okay.
Because you know what type of tumor you're dealing with and how aggressive it is.
So the article, it highlights some specific situations where RMB is really recommended.
Yeah.
Let's get into some of those.
So for tumors between 20 and 40 millimeters in size,
Okay.
RMB is super effective, and there's growing support for using it on even smaller tumors,
Oh, wow.
like those under 20 millimeters.
I guess the earlier the better, right?
Oh, yeah, for sure.
Yeah.
Early detection and accurate diagnosis are just critical in cancer care.
Right. Absolutely.
Another area where RMB is really useful
Yeah.
is in pre-ablation assessment.
Remind me what ablation is.
So ablation is when they use heat to destroy a tumor.
Okay.
It's called thermal ablation.
Got it.
So RMB can help determine if that's even the right approach,
Right.
especially for a type of tumor called clear cell RCC,
RCC.
renal cell carcinoma. It has a higher risk of coming back.
Oh.
So you want to make sure you're using the most effective treatment.
Really make sure that it's targeted to that specific tumor type.
Exactly. It's about tailoring the approach for each patient.
Tailored treatment plans.
Yeah.
I like that.
Better outcomes, hopefully.
The article also mentions that it's great for patients who have multiple comorbidities.
Yeah, it is.
And for those with multiple tumors.
Yes.
Interesting.
And you can even use it to differentiate between metastasis to the kidney versus a new primary renal tumor
Okay.
when a patient has a history of cancer outside the kidney.
So many different applications for it.
Yeah.
But how accurate is it?
That's a good question.
Yeah.
You want to know it's doing its job.
Right.
So the article cites a systematic review that found the median diagnostic rate of RMB is 92%.
Wow.
That's pretty high.
That's pretty good.
It also has high sensitivity and specificity.
Which means...
It's very good at correctly identifying both cancerous and benign tumors.
So low chance of false positive or false negative.
Yes, relatively low.
That's reassuring.
There's also good concordance between the biopsy results and
Yeah.
the histotype of the surgical specimen.
Okay.
So basically what they find in the biopsy is usually confirmed when they look at the entire tumor.
Oh, interesting.
Yeah.
After surgery. So I guess if they do need to remove the tumor, they've got a pretty good idea of what they're dealing with.
Yes, exactly.
Now, of course, no procedure is without its risks. So what are the potential complications here with RMB?
Thankfully, complications are rare.
Okay, good.
The most common is bleeding,
Okay.
but it usually resolves on its own.
Bleeding.
Yeah.
Okay.
A less common issue is tract seeding.
Tract seeding. What is that?
So that's when tumor cells spread along the path of the biopsy needle.
Oh, okay.
It's a serious concern,
Yeah.
but luckily it doesn't happen very often.
Yeah.
Less than 1% of the time.
Good to know.
Yeah.
So we've got this tool.
Right.
It can diagnose a wide range of these kidney tumors.
Uh-huh.
It's generally safe.
Yeah.
But then we get to the classification of these tumors.
Right.
That's where it gets really interesting, right?
Absolutely.
That's the challenge.
Yeah.
Because kidney tumors they're not all the same.
No, they're not.
There are so many different types.
Yes.
And with all the advancements in imaging
Right.
and biopsy and molecular diagnostics,
Yeah.
the classification of these tumors has gotten so complex.
Yeah. Incredibly complex. It's a real challenge for pathologists.
Yeah,
Trying to keep it all straight.
I can only imagine.
Yeah, it's a lot.
So how do they make sense of it all?
Oh, that's the big question. We'll
Yeah.
get into that. So how do pathologists make sense of it all?
Yeah, like what's the practical approach?
Well, the key is to kind of move away from classifying tumors based just on their microscopic appearance
Okay.
or their molecular features.
Right.
And instead, we're moving towards grouping them based on how they behave clinically,
Okay.
their prognosis.
So less about the tiny details of each subtype,
Yeah.
more about, okay, is this tumor
Right.
benign?
Right.
Is it indolent?
Yes.
Is it malignant?
Uh-huh.
Aggressive?
Exactly.
Okay.
So it's really about taking all this complex information and making it useful for treatment.
Actionable.
Exactly.
So let's go through some examples
Okay.
of these different prognostic groups
Sure.
and the
Yeah.
types of tumors
Yeah.
that fall into each.
All right. Well, let's start with the good news.
Okay.
The benign tumors,
Okay.
these typically don't require any intervention
Mhm.
other than just monitoring.
Okay.
So some of the most common ones you'll see are renal angiomyolipoma,
Wow.
or AML for short.
Okay.
And then there's renal papilloma
Mm-hmm.
and oncocytoma.
Oncocytoma, that's a mouthful.
It is, but essentially it's a benign tumor made up of cells
Okay.
that are packed with mitochondria.
Mitochondria, those are the powerhouse.
Yes, the energy producers of the cell.
Yeah, back to high school biology.
Exactly.
So if they find one of these benign tumors, they can just breathe a sigh of relief.
Pretty much, yeah.
Okay.
They'll still need to be monitored
Okay.
to make sure nothing changes,
Okay.
but active treatment's usually not necessary.
All right. What about the next level up then?
Okay, so then we get into the tumors with low malignant potential, or LMP.
LMP. Okay.
These are kind of a gray area.
Okay.
They have the potential to become cancerous,
Right.
but they grow very slowly.
And they don't typically spread.
So more of a wait-and-see approach.
Well, not necessarily.
Yeah.
Active surveillance is definitely an option,
Okay.
but depending on the specific tumor type
Right.
and the patient's individual situation,
Yeah.
thermal ablation or even a partial nephrectomy might be recommended.
Okay.
So it really depends.
Got it.
Two common ones in this category are papillary adenoma
Okay.
and then oncocytoma again.
Oncocytoma, it's back.
It's back.
I thought we said it was benign.
It is benign,
Well,
but it can sometimes mimic other more aggressive types of oncocytic tumors.
Tricky.
So even though it's benign, it still needs to be watched carefully
Okay.
and sometimes treating on, depending on how fast it's growing and other factors.
So it really is all about the nuances
Yes.
in this world of kidney tumors.
There's a lot of overlap
Mhm.
between different subtypes.
Okay.
The pathologist really has to be on their game
Yeah.
to make the right call.
So we've covered the benign, right?
We've covered the low malignant potential.
Yep.
What about the ones that need more proactive treatment?
Okay, so then we move into the intermediate prognosis group.
Okay.
These tumors are more likely to behave malignantly,
Okay.
but they don't necessarily spread rapidly.
So still kind of in between.
Yeah.
Okay.
And the treatment for these is usually more aggressive,
Okay.
often a partial or radical nephrectomy.
Okay. So examples of these intermediate risk tumors.
So one you might see is mucinous tubular and spindle cell RCC.
That's a mouthful.
It is. We call it MTS-RCC for short.
MTS-RCC.
Yeah, and it's characterized by, you guessed it,
Mucin.
mucin, that sticky substance,
Yeah.
and spindle-shaped cells.
Well, it's kind of a mixed bag.
It is a mixed bag, yeah.
Okay.
And that's one of the things that makes it tricky to diagnose,
Okay.
because the biopsy might show mostly spindle cells,
Mm-hmm.
which can make you think of a more aggressive tumor,
Okay.
like sarcomatoid RCC,
Right.
but the mucin helps point towards MTS-RCC.
So you need that extra clue,
Exactly. Context is key.
just like in research, right?
Precisely.
Okay. What else?
And then there's acquired cystic disease-associated RCC,
Okay.
or ACD RCC.
RCC.
This one's linked to end-stage renal failure
Oh, wow.
and a history of dialysis.
So these patients have already been through a lot.
Yeah, unfortunately.
And then they get this tumor.
Wow.
And it can be hard to diagnose on a biopsy
Okay.
because it can mimic other types of RCC.
Those mimics again,
Yeah, they're everywhere.
making things difficult,
It's a real head scratcher
I bet.
because misdiagnosis could lead to undertreatment
Right.
or overtreatment.
And neither of those is good.
Not good, no.
So we've gone from benign to malignant potential
Yep.
to intermediate.
Uh-huh.
I'm guessing the next step is?
The malignant tumors.
Okay, so these are the ones...
These are the ones that are clearly cancerous
Okay.
and have a higher risk of spreading.
This is where things get really serious.
It is, yeah.
Yeah. The treatment is usually more aggressive,
Right.
typically involving a partial or radical nephrectomy.
Okay, some examples of these.
So one that comes up often is epithelioid angiomyolipoma,
Okay.
or EML.
EL.
It's important to recognize this one because it can mimic other more common types of RCC.
Oh, no, not the big standard.
Profibrocs are back.
They're always lurking.
They're always there.
Okay, so what can we look for to tell them apart?
So EML often has a distinct look under the microscope.
Okay.
We call it epithelioid.
Epithelial.
The cells are large and polygonal
Okay.
with prominent nucleoli.
So they look different from the cells.
Yes, different from other RCC types.
Interesting.
And they also have a unique immunohistochemical profile.
Okay.
So they stain positive for certain markers like
Right.
HMB45, melon A, and SMA.
Got it.
And other RCCs might not.
So immunohistochemistry is really helpful here.
It's super helpful for
Mhm.
making these distinctions.
And then what about papillary RCC?
Papillary RCC, yes.
We talked about that a little bit before.
We did.
Easily confused with papillary adenoma,
Exactly.
but papillary RCC.
They tend to be larger
Okay.
than the adenomas,
Right.
and they have more aggressive features,
Okay.
like high nuclear grade.
Right. And their immunohistochemistry profile is different.
It is different, yeah.
So, for example.
Papillary RCCs are often negative for CK7,
Okay.
while the adenomas usually stain positive for it.
Got it. So, subtle differences, but important.
Very important.
What else is there?
And then there's a unique subtype of papillary RCC called papillary renal neoplasm with reverse polarity.
Wow. That's a mouthful.
It is a mouthful.
Yep.
We call it PRNRP for short.
Okay. PRNRP.
It's known for having mutations in the KRAS gene.
Okay.
And it usually has a more indolent course.
I want to make sure we're not over-treating.
Exactly.
Okay.
But diagnosing it can be tricky
How so?
because it can mimic other RCC types,
Of course.
especially clear cell papillary renal tumor. I know, they're always there,
Always lurking.
but there are some clues.
Okay.
PRNRP often has this distinctive pattern.
Okay.
We call it reverse polarity.
Reverse polarity.
It means the nuclei are located at the top of the cell instead of the bottom.
Interesting.
It's like the cells are standing on their heads.
I like that analogy.
And it also has a unique immunohistochemical profile.
Right. So we can use that to help us.
Absolutely.
Okay. What else?
And then we have TFEB rearranged RCC.
Okay.
This one has a specific genetic alteration,
Okay.
a translocation involving the TFEB gene.
Translocations. We talked about those earlier.
We did.
Didn't sound good.
They can be a cause for concern
Right.
because they can lead to fusion genes that can
Yes.
drive tumor growth.
So TFEB rearranged RCC is something to watch out for.
It can be,
Yeah.
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 But thankfully, it's relatively rare.
Okay.
Only
That's-
about 9% of all translocation RCCs.
Still, how do we diagnose it?
It can be a challenge to diagnose because it can look different under the microscope,
Right.
but it often has this biphasic pattern.
Bifid.
Two distinct cell types,
Okay.
large epithelioid cells and smaller cells with dark nuclei.
So like a two-toned tumor.
Yeah, that's a good way to put it.
Okay.
And it also has a distinct immunohistochemical profile,
Okay.
staining positive for markers like melon A, HMB45, and cathepsin K.
So again, we can use that to help us.
Absolutely.
Okay, so we've gone from benign to low malignant potential to intermediate to malignant.
Yeah.
I'm guessing the only place left to go is...
The high-risk tumors.
Okay, let's talk about those.
So these are the ones that need the most aggressive treatment.
Right.
Usually a radical nephrectomy.
So we're pulling out the big guns.
Yeah, we need to be able to recognize these early
Mm-hmm.
so we can act quickly.
What are some of the red flags here?
Well, one is the presence of a translocation.
Right, we talked about those.
We did.
Not good.
And there are two main types of translocation RCCs.
Okay,
TFE3 rearranged
right.
and TFE altered.
So these are the ones that we really have to be concerned about.
They can be very aggressive.
Yeah.
And they often don't respond well to standard therapies.
So the pathologist really needs to be on high alert.
Absolutely.
Okay.
They need to be able to distinguish them from other types of RCC.
That's got to be tough.
It can be challenging, yeah.
Especially when they could look So similar.
But we have tools like immunohistochemistry
Right.
and SBS.
It's
Yeah, it uses fluorescent probes to detect specific genetic alterations.
okay.
So it's kind of like detective work.
Right, piecing together the clues,
From the biopsy, the imaging,
Yeah.
and the molecular testing.
all of that combined.
And then there's another high-risk tumor that's particularly concerning.
Okay.
It's called fumarate hydratase deficient RCC,
Okay.
or FH deficient RCC for short.
FH deficient.
This one is often hereditary,
Oh, okay.
and it has a high risk of spreading.
To other parts of the body.
Yes.
So if they find this on a biopsy,
Yeah.
the patient's family members
They might need to be screened.
for this genetic mutation.
Exactly. Early detection is key.
Okay, so what are the key features of this one?
So FH deficient RCCs, they often have a unique look
Okay.
under the microscope.
Yeah.
They tend to have a papillary architecture,
Okay.
and the cells have abundant eosinophilic cytoplasm.
Eosinophilic cytoplasm.
It means they stain pink
Okay.
with a special dye
Okay.
called eosin
Okay.
and the nuclei of the cells.
Mm-hmm.
They often have prominent nucleoli
Okay.
with a distinct perinuclear halo.
Perinuclear halo. What's that?
It's just a clear space
Okay.
surrounding the nucleolus.
Okay, so they've got a distinctive look.
They do.
Okay, what about immunohistochemistry?
They also have a unique immunohistochemical profile.
Right.
They're negative for a marker called FH,
Makes sense.
and they stain positive for a marker called 2SC.
Okay, so morphology and immunohistochemistry can help us here.
Exactly.
All
And
right.
finally, we have ALK rearranged RCC, another rare but aggressive tumor.
And it's got a translocation.
It does, involving the ALK gene.
Translocations everywhere with these high-risk tumors.
They're very common in this category, yeah.
So how do we diagnose this one?
Again, it can be tricky
Okay.
because it can look like other high-grade RCCs
Right.
under the microscope.
Mm-hmm.
It might have a papillary architecture,
Okay.
or it might be composed of cells with a signet ring appearance.
So signet ring appearance, what does that mean?
So it means they have a large vacuole
Okay.
that pushes the nucleus to the side.
Okay.
So the cell looks like a ring with a stone in it.
So it's like a master of disguise.
It's a good way to put it, yeah.
Okay. But we have tools to help us.
We do.
Yeah.
We have immunohistochemistry
Mhm.
and FH.
Fasciolage.
So ALK rearranged RCCs, they usually stain positive for a marker called ALK.
Okay.
And we can use Sun-Fashac to confirm the translocation.
Wow, molecular diagnostics are amazing.
They're really helpful in these situations.
Yeah, they're lifesavers.
Yeah.
Wow, we've really journeyed through a complex world, haven't we?
We have. It's so intricate.
All these kidney tumors.
Yeah, and it shows how important it is to have a systematic approach to diagnosis.
Mm-hmm. Yeah, absolutely.
You know, careful evaluation of the morphology,
Right.
and then using immunohistochemistry and molecular diagnostics.
But needed.
As needed, exactly.
You get that accurate diagnosis and guide treatment.
Yes, that's the key.
But even with all these tools,
Right.
it seems like diagnosis can still be tricky.
It can be, yeah.
All this overlap between subtypes.
Yeah.
And those mimics.
The mimics, they're always there,
Always lurking.
making things difficult.
It really emphasizes how important it is
Yeah.
to have experienced pathologists
Oh, absolutely.
who really know these kidney tumors
Mhm.
inside and out.
They're like the detectives of the medical world,
Yeah, like that.
piecing together all the clues.
And the stakes are high, right?
very high.
It's someone's life we're talking about.
Exactly.
So this also highlights, I think, the importance of continuous research in this field.
Absolutely. We need to keep learning
Yeah.
to develop even better treatments.
Right, better outcomes for patients.
That's the goal.
Okay, so we've talked about the need for RMB,
Uh-huh.
talked about its accuracy,
Yeah.
the complexity of classifying these tumors,
Yeah.
and all these different tumor types.
From benign to high risk.
Are there any other key takeaways
Yes.
from this review article that our listeners should keep in mind?
I think one of the most important takeaways is just recognizing how valuable RMB is as a tool for diagnosing and managing kidney tumors.
Right. It can prevent those unnecessary surgeries.
Exactly. It helps avoid those.
And it leads to more personalized treatment plans.
Yes, because you have a definitive diagnosis.
Right. You know what you're dealing with,
You're not guessing,
which leads to better outcomes for patients.
hopefully. Yeah.
So that's one key takeaway.
Uh-huh.
What's another one?
Another key takeaway is that the world of kidney tumors
Right.
is incredibly complex.
We've seen that.
There are so many different types
Mhm.
and subtypes,
Mm-hmm.
and many of them can mimic each other,
Right. Those mimics.
which makes accurate diagnosis a real challenge.
Absolutely. So how do we approach this then?
Well, we need a structured approach.
Okay.
Start with a thorough evaluation of the morphology.
Right, how it looks.
Exactly.
Under the microscope.
And then we use immunohistochemistry and molecular diagnostics as needed
As needed.
to really refine that diagnosis.
Okay, so structure is key.
Structure is key.
Oh.
I think the third takeaway is the importance of grading.
Okay.
And necrosis.
Right, we talked about those.
We did.
So grading is basically...
That's how we assess how aggressive the tumor is likely to be.
Based on
how abnormal the cells look under the microscope.
Right, so a high-grade tumor...
A high-grade tumor is more worrisome.
Yeah, more aggressive.
More aggressive, exactly.
Than a low-grade tumor.
And we use the Furman grade
Okay.
to grade kidney tumors.
Right, the 1 to 4 scale.
Yes, 1 to 4.
1 being the least aggressive,
That's
4
right.
being the most aggressive.
Exactly.
But, like we said, grading isn't always easy.
No, it's not always straightforward.
Right, because of...
Tumor heterogeneity.
Heterogeneity, what was that again?
It means different parts of the tumor might look different.
Oh, interesting.
Under the microscope.
So the biopsy sample might not be representative?
Exactly.
Oh, exactly.
And then there's interobserver variability.
Which is?
Different pathologists might look at the same sample
Okay.
and give it a slightly different grade.
So there's a subjective element to it.
There is, yeah.
Okay, so we have to take that into account.
Absolutely.
What about necrosis then?
Necrosis, so that's the death of tissue within the tumor.
Right.
And it can be a sign
Of what?
of aggressive tumor behavior.
Okay.
Especially in certain types of RCC, like clear cell RCC.
So if there's necrosis present...
It might bump the tumor up to a higher grade, and it might change the treatment plan.
Okay, so grading and necrosis are important.
Very important.
What else?
Another key takeaway is the role of RMB in identifying hereditary forms of RCC.
Right, the genetic component.
Exactly.
Some of these RCCs can run in families.
Yes, like FH-deficient RCC.
Right.
And some types of papillary RCC.
So it's not just about diagnosing the patient.
Right.
But also potentially their family members.
Exactly. It could have implications for the whole family.
And then there's the role of RMB.
Yeah.
In guiding treatment.
Yes, especially for advanced or metastatic RCC.
So when the cancer has spread.
Exactly.
Okay.
So in these cases, RMB can help determine the specific subtype of RCC.
Right, because that can affect treatment.
It can, yeah.
So different subtypes might respond differently.
To different therapies.
To different therapies, okay.
So it's about getting as much information as possible.
Right, to make the best treatment plan.
To personalize the treatment plan.
Okay, and last but not least.
One more takeaway.
What's that?
It's about the pathological consequences of RMB.
Pathological consequences.
Yeah, so basically the pathologist needs to be aware that a biopsy was done. Right. When they're examining the nephrectomy specimen.
The nephrectomy specimen, that's the...
That's the surgically removed kidney.
Okay.
Because the biopsy needle can cause some damage.
Okay.
And inflammation.
Right.
Which can make it harder to interpret.
So that's what's really going on.
The true features of the tumor.
Right. So, for example...
They need to be able to distinguish between post-biopsy necrosis and true tumor necrosis.
Ah, so it can complicate things.
It can, yeah.
So it really is a team effort.
It is.
You've got the radiologist doing the biopsy, the pathologist looking at the results, and the surgeon examining the removed kidney.
They all need to be on the same page.
Absolutely.
Communication is key.
It's fascinating, isn't it?
It is.
This whole world of renal mass biopsy.
It's really remarkable.
Yeah, it's clearly becoming a crucial part of diagnosing and managing these kidney tumors.
It is. It's changing the way we approach these cases.
Absolutely.
And helping to improve outcomes for patients.
But as we've seen, it's not without its challenges.
It's true.
This whole classification system, all these different tumor types, the potential for mimics.
The mimics.
It really requires expert interpretation.
It does, yeah.
So we need those skilled pathologists.
We do.
More than ever.
Absolutely.
And we need to keep pushing forward with research.
Yes, we need to keep learning.
To better understand these tumors and develop even more effective treatments.
That's the goal.
It's exciting though, right?
It is exciting.
To be a part of this.
It's a dynamic field.
Yeah, always evolving.
Always new discoveries.
Before we wrap up,
I
want to leave our listeners with a thought.
Okay.
You know, with all these advancements in molecular diagnostics.
Right.
Where do you see the role of RMB heading in the future?
I think we're going to see RMB become even more closely integrated with molecular diagnostics.
Okay.
So we'll be able to get a much more complete picture of the tumor's genetic makeup.
Right, even more personalized treatment.
Exactly.
Right.
And we might even see new biopsy techniques
Okay.
that can get us more representative samples
So that'd be great.
to minimize the risk of errors.
Right. Reduce those misdiagnoses.
Yeah, it's a really exciting time to be in this field.
It sounds like it.
Lots of potential.
Yeah, the future of R&B is bright.
I think so too.
Well, this has been a really fascinating deep dive
It has.
into renal mass biopsy.
I've enjoyed it.
We've uncovered its importance,
Yeah.
explored all the complexities, and really seen how it has the potential to transform how we approach kidney tumors.
It's a game changer.
Absolutely.
I hope our listeners have learned a lot
I'm sure they have.
about this important procedure.
Absolutely. Until our next deep dive,
Yeah.
keep those minds curious
Stay curious.
and those brains engaged.
Always learning.